I'm afraid this isn't the most appetizing presentation for right before lunch, but we'll try and make it as painless as possible here. I've worked with the Venous Nursing, I've worked with the Vascular Nursing Association for over 10 years now, and one of the things that we try to do is educate people about what is going on with leg ulcers or other types of vascular stuff. There were some guidelines that came out in the Journal of Vascular Surgery in August of 2014, and in our journal we wanted to have this condensed down for nursing, and so that's what happened. I wrote an article about it, and then I'm doing this presentation after I did the article. So, okay. So this is the reference for the article that originally came out. It was in the Journal of Vascular Surgery, and when you see surgery there, that should clue you in that this was the vascular surgeon. So the Society of Vascular Surgery and the American Venous Forum, and the Venous Forum is a combination of nurses and physicians that are medical physicians and other kinds of workers. And so there was a good cross-section of people who work with vascular disease that were evaluating this. There were 6 subcommittees that were divided out, and they graded all of the evidence. So when you're talking about this evidence-based practice, they looked at all the evidence that they could find about different aspects of venous ulcer care. And a 1 was given if it was a recommended practice, a 2 was given if it was a okay practice. And then an A meant it was strong evidence, a B meant it was moderate evidence, a C meant that it was weak evidence. And in many places, they just had to use best practice because there was no actual research. Venous ulcers have a big impact on life. We've talked about caregivers and things like that. 70% of all leg ulcers in the world have a venous type of origin. And this will affect 0.6 to 0.2% or 2% of the population. That's like anywhere from 6 to 20 people in 1,000. So a lot of people are affected by some type of venous problem this way. It has a huge financial impact. The rising cost of the special treatments it's just going all higher and higher all the time throughout the world. But there's lots of the hidden costs. There is loss of income. They do require assistance, the caregiving, and a lot of times the people that are giving the caregiving are not allowed to work or have limited amount of time to work, so they lose income that way. And then there's a lot of travel costs when they're going for any kind of special procedures. So nurses work a lot with this group of people. They're either the care manager or they are working with care managers to try and make this work well. Now this is just to remind you about the anatomy and physiology. You learned this in nursing school, so this is probably not necessary, but just to remind you about these legs. You have the deep veins, you have the superficial veins, and you have the perforating veins. And each of these has a valve. And in the valves, if they're competent, then the fluid does not go from the head down to the foot. It goes back towards the head. And when the muscles are contracting, then the fluid is going up through those vessels towards the head. When that doesn't happen, there are reasons why that doesn't happen. The hydrostatic pressure may be too high in the vessels, and you see here in the bottom side, this is what happens with varicose veins, and varicose veins can very much contribute to the development of those venous leg ulcers. So when you have those poor valve closures, you have the excess volumes, then they're more likely to have deterioration of that skin in the ankle areas. So I'm sorry, this is ugly, but I tried to keep it little. You're going to see the warmth and erythema that occurs from inflammation. A lot of times there's cellulitis that happens in the area around the wound. You have dilatation of the vessels in that area. A lot of times there's a brownish discoloration around the ankle. It could be from healed wounds from the past, or it could be from other things. Edema is almost always present in the tissues around the wound, and the wounds will have very irregular edges and lots of drainage. If it is clear, serous drainage, then that's probably a good sign, because many times it is not. So how do you prevent these venous leg ulcers? You get people to elevate their ankles, and this is an early thing. Graduated compression stockings need to be worn. As nurses, we are a population that is very prone to getting varicose veins, and in our older ages, we could get these ulcers. So start thinking about getting your graduated compression stockings to wear, especially if you're going to be on your feet for long shifts. Venous calf pump exercises. I mean, we've done this dorsiflexion and plantar flexion with our patients forever, but remembering to do that so that it doesn't not get done. Getting them to ambulate as much as possible. And nurses are very involved in all of that preventative care and education. And as nurses, we think, well, everybody knows this, right? And what we've discovered is people don't. You know, they could be standing there at the cash register all day and they're getting their varicose veins and they're getting horrible swollen ankles and they have no idea why it's happening. I mean, just walking in place while they're standing there could help them prevent that. Diagnosis, mainly it was just best practice that they could find as far as who should evaluate it. A vascular specialist was the ideal. They did use a CEAP tool, which tells what is that actual, what is the stage that it's at right now. And I'll call it a C5 or a C6 later. A C6 would be an open wound and a C5 would be a healed wound. They also said that a venous clinical severity score was very important because that tells over time whether the treatment has been effective or not. And then a venous disease specific quality of life scale is very important because this very much diminishes quality of life. As far as level 1 or recommended type of treatments, they wanted a venous duplex ultrasound for the initial diagnosis, and then the ankle brachial index is also important, and that's what's pictured in the little square there. You cannot do this over a wound. So they couldn't do the ankle pressures over a wound area, so they have little, they can do toe pressures, and they can get that. But the reason that they need to know about the arterial is just because they have venous disease does not mean they don't have the arterial disease at the same time. Wound biopsies could be done, but the wound has to have been there for 4 to 6 weeks not healing. So you don't rush out and do biopsies right away. Plasmography is a lot of times ordered for venous disease, and they were like, well, yeah, it's okay, but it's not that special, and that's what's pictured there at the bottom. Laboratory testing, only if they have a history of DVT do you want to do the thrombophilia testing. Only if they're going to have a surgical intervention do you want to do the excessive testing otherwise. General wound care, nurses do a lot of this. We are the ones that are going to be very involved in that. We want to promote nutrition. We want to make sure that the size and shape of that wound is documented on a regular basis, at least weekly, if not you know, if they're coming in that often. If you're in the hospital, they say if you try and document it every day, you're not going to see changes, and so you have a tendency to just not do it at all. So if you just have a certain day that you're going to do those measurements, that helps. Anytime you're cleansing these wounds, use a non-irritating solution. So you use saline. You don't use something that's going to irritate the wound. Debridement, they said, is very important. They want surgical debridement mostly, and they may need some maintenance type of debridement to remove any of the slough type tissue, anything that's getting in the way that could become infected. Local or stronger anesthetic is always recommended when they're going to do that, and surgical or hydrosurgical type of therapy. So it may just be the physician coming to the bedside with the scissors and clipping, or it could be that they're putting them in a whirlpool type of thing to get the slough off. Ultrasound was discouraged. They said it was too slow a process and too expensive. And enzymatic and biological larva type treatments were only good if you did not have someone who could actually do the surgical debridement. That if you have someone who's too sick to actually have that debridement done, then, or you have no one around that can do it, then the enzymatic and the biologic were good in these wounds. They have their place, but this was not it. Okay. Infection control and the primary dressings was another focus that they looked at. They said most of the infections are going to be treated best by a gram-positive antibiotic, and it's usually when there's cellulitis that you need that, if there's an obvious ulcer infection, and I'm not going to describe that because it's right before lunch. Combination of debridement and antibiotics in a highly infected wound, but you really don't want to do a lot of debridement in an infected wound initially because you could get that infection into the bloodstream. You want absorbent dressings that are protective of the area around the ulcer and are going to be a warm, moist area. But because there's so many secretions, you don't want to do topical antibiotics, antimicrobial dressings, and anti-inflammatory dressings because those tend to be much more expensive, and they're kind of a futile thing at this point because it needs to be treated otherwise. Supportive therapy is ways that they get the wound to heal faster, and they say after about 4 to 6 weeks with it not healing, that's when you might think about doing these, not earlier. Cellular therapy is when they take just individual cells and scatter it across a wound. It can be a fairly small wound. And then split thickness grafts would be used with large wounds, and they have to be done in combination with compression therapy, because if they don't have the compression therapy, the edema will cause it to not be able to stick. They recommended against negative pressure therapy, electrical stimulation therapy, and ultrasound therapy. Compression is something that always needs to be present when there's venous leg ulcers. And in this case, you saw before that the ulcer was down around the ankle, but you see this compression goes all the way up the leg. So you need that compression to go all the way up the leg. Otherwise, you tend to have that overfill into the superficial vessels. Compression with an active ulcer, the CEAP6, is very important. Ongoing compression, even after it heals, is recommended. Multi-component versus single component, they said there really wasn't a lot of research that showed one preferable to the other. No compression when an ABI or the ankle brachial index was less than 5, or the systolic pressure in the ankle was 60 millimeters of mercury or less, because you're going to cut off the arterial flow and you're going to inhibit healing. Intermittent pneumatic compression is better than no compression at all. In many patients with leg ulcers, they'll have a tendency not to put even the intermittent pneumatic compression on there, but they said some is better than none. So nurses teach a lot of this. We do a lot of the actual dressings. We have a power to recommend what dressings we think that should be done. We have a way that we can look at the evidence and try and bring it forward for people to look at. So it's important for us to be knowledgeable about that. Endovascular and surgical interventions. Now, the document that I was doing the summary of was around 150 to 200 pages long. The summary that they had at the front was 33 pages to start with. And the majority of it had to do with endovascular and surgical interventions. But do nurses do those? No. So you have one slide here that is very minimal, because nursing is going to be involved in this is preoperative teaching, postoperative care, looking at the wounds, doing the dressings, doing that kind of thing. There are some advanced practice nurses that can do the ablation therapy, and if you have a wound that is has massive amounts of drainage and even has bloody drainage, then they say you should ablate those areas, but any kind of ablation is okay. So it can be ligation, nurses don't do that, physicians do that, but sclerosing a vessel, yeah, a lot of times nurses, advanced practice nurses will put in the solution that causes vessels to sclerose. So there may be ways in which we are involved with that. The superficial venous areas are done first, and then they'll do the perforator vessels if the superficial vessels don't help. With infrainguinal, if they have blood clots and things like that that are causing a lot of the edema, then they may go in and remove those clots, remove it, but they say that in the past people have gone in and ligated the popliteal or the femoral artery, and that is definitely not suggested at all. The iliac and inferior vena cava problems that happen, a lot of times there can be sclerosis in those areas, so there's a decreased blood flow because of one reason or another. And so they can go in and do angioplasty and stenting in the veins. We usually think about this in arteries only, but they can do it in the veins, in the vena cava, and the iliac vessels. So in conclusion, nursing care has changed little from what we did previously. Advanced practice nurses and vascular care may be involved in the debridement and ablation activities, but otherwise we mainly are going to be doing the teaching and supportive care, a lot of education with your patients, the caregivers, with everybody involved in the situation. And prevention is the best treatment. So trying to do a lot of education before these ulcers ever happen is best. Compression is going to be the gold standard forever, I think. So if you don't know about how doing compression, it's something you may want to learn. Okay. So questions? I think they're all hungry.